So my name is Sven Poli. I'm the co-PI of the ATTICUS trial. I'm stroke physician at Tübingen University Hospital. The background of ATTICUS is basically that optimal therapy after ESUS is still not established. We had two randomized control trials evaluating DOAC in unselected ESUS patients, and they showed negative or neutral results regarding efficacy of DOAC over aspirin in this population, in this unselected ESUS population. The background of using DOAC in ESUS patients is that we assume that high percentage of these patients may suffer stroke from cardioembolism, basically due to atrial fibrillation. And what we did in ATTICUS is we, by using certain predictive factors for the occurrence or for the presence of occult atrial fibrillation, like clinical echocardiographic and electrocardiographic predictive factors, to enrich the ESUS population enrolled in ATTICUS, and thereby focus on a high risk population. Additionally, we used cardiac monitoring or AF monitoring during the whole period of study participation. That's basically the differences compared to the RE-SPECT or the Navigate phase 3 ESUS trials.
So my name is Tobias Geisler. I'm an invasive cardiologist located in the same institution like Sven Poli, the University Hospital of Tübingen. And my main scientific focus is atrial fibrillation and thrombosis. And before I start to give you an overview about the study design, I want to highlight that it is important, in particular in this patient population, that there's a close collaboration between neurologists and cardiologists. Because many patients that are affected by ESUS have a source of cardiac embolism. And for that reason, we decided even before the study started to develop a workup, a cardiology and neurology workup to identify risk predictors to determine or to increase the probability of a cardiac embolism. And that workup was included in ATTICUS. So Sven Poli already mentioned that we demanded that at least one risk factor for cardiac embolism should be present for enrollment of the patient. That was left atrial size of above 45 millimeters, a spontaneous echo contrast in the left atrial appendage, a reduced LAA flow velocity, or the detection of so-called atrial high rate episodes, and a clinical increased risk for cardiac embolism, for stroke, which is a SCHATZFA score of at least 4, or the presence of a patent foramen ovale. So whenever a patient had an ESUS and one of these risk factors, the patient was randomized quite early after the stroke. That's different to the other ESUS trials where the inclusion was more after 4 weeks. So at median, the enrollment in ATTICUS was at 8 days after the index stroke, and it was also allowed to enroll major strokes, albeit the prevalence of a major stroke was quite low in ATTICUS. So these patients were randomized to aspirin as a standard treatment at 100 milligram once daily, or Apixaban 5 milligram twice daily, and the dose was reduced according to the label in patients with renal insufficiency and an elderly patient and low body weight patients. And the primary endpoint of this trial was any new ischemic lesion detected on MRI after 12 months. So Sven Poli already mentioned that we demanded an intensive monitoring of atrial fibrillation because due to the pre-selection criteria, we think that the prevalence is very high of atrial fibrillation. So patient could be switched, of course, or had to be switched, of course, once atrial fibrillation of more than 2 minutes was detected in the aspirin arm, and we performed additional imaging and MRI at the time point of switching from aspirin to Apixaban. We also investigate a number of secondary endpoints and explorative endpoints, and we will come to this later. Thank you.
We had an adaptive study design, and we made an interim analysis after 200 patients enrolled. 165 have been evaluable at that time point of interim analysis, and the trial was terminated due to futility based on the interim analysis. Finally, enrollment, etc., continued until that point, and for the final analysis, 352 patients have been enrolled. So looking at the baseline characteristics of all 352 patients, they have been well distributed between the two study arms. We had a somewhat little older population compared to RE-SPECT and Navigate ESUS, so 3 to 4 years older patients with well-distributed sex between male and female, 50%. We had higher percentage of risk factors, 10% more of hypertension and around 5% more of diabetes in our population compared to RE-SPECT and Navigate. And what was most impressive was the time from index stroke to randomization was 8 days in median, compared to 46 days in RE-SPECT and 38 days in Navigate ESUS trial. So we started to work very early after index stroke. There were two differences regarding history of cancer and PFO, which were more present in the Apixaban arm. When looking at the primary endpoint, which was available in 325 of the 352 patients, there was no significant difference between the primary endpoint, which was new ischemic lesions at 12 months, between Apixaban arm and aspirin arm. But you have to keep in mind that, again, aspirin was switched to Apixaban whenever atrial fibrillation occurred.
So continuous cardiac monitoring was mandatory in an ATTICUS, and we mainly used the Medtronic Reveal link system, which allowed it also for central adjudication of the atrial fibrillation episodes of more than 2 minutes. We also included another system, which is the PhysioMem system, which allows for several times daily ECG monitoring to allow also for retrospective analysis of atrial fibrillation load per day. So these are the results with regard to atrial fibrillation detection, and what we anticipated by enrichment of the population actually fulfilled, that we have a very high prevalence of atrial fibrillation, and you can see at the Kaplan-Meier curves that if a patient had atrial fibrillation, it was in most cases detected within the first 20 weeks. So the prevalence at the end of the study of atrial fibrillation was 25%, 0.6% in the whole population, meaning that every fourth patient had atrial fibrillation. And there were slight differences with regard to atrial fibrillation detection between the arms. So more patients in the aspirin arm, 28% approximately, had atrial fibrillation detected of more than 2 minutes. And that, of course, led to a switch from aspirin to Apixaban in these cases. You see that there is numerous trends of less ischemic endpoints in those patients that had been detected atrial fibrillation, although this effect and the interaction was non-significant.
What needs additionally to be said in this case is that also in those patients that did not exhibit atrial fibrillation during the course of the 12 months, Apixaban and aspirin were equally potent in preventing new ischemic lesions. So there was no trend towards aspirin, which you might think in macroangiopathic stroke could be better. No, both medications did a good job in preventing new ischemic lesions.
Of course, we have previous trials that deal with atrial fibrillation detection after ESUS or cryptogenic stroke. That is the Crystal AF study and the EMBRACE study. And these trials found that about 12 to 15% of patients had atrial fibrillation during a 12-month observational period. So with this design, we almost doubled the detection rate of atrial fibrillation and in this enriched population.
This was, by the way, already shown, this high rate of atrial fibrillation detection in our own small study, which we conducted in 2014, when we selected patients based on the exact same AF predictive factors that we also used in the ATTICUS trial. So we achieved something around 30% within 12 months. So again, double the number compared to Crystal AF within this short period of time. When looking at the clinical endpoint, recurrent stroke, which were, by the way, all ischemic. We had no case of intracranial bleed. They occurred in the same range as what has been seen in Navigate and the RE-SPECT study, so around 5% or somewhat higher in the ATTICUS trial, again with no difference between the two arms. And also the other clinical endpoints, such as the combination of ischemic stroke, TIA, systemic embolism, pulmonary embolism, myocardial infarction, and all-cause death, and the combined endpoint were same in both arms.
Due to the study design and the early use of anticoagulation after stroke, safety is, of course, a major issue in ATTICUS. This is actually the first study that investigated the role of anticoagulation that early after stroke. And for that reason, the safety findings are very important. And you can see that there were hardly any differences with regard to SAEs between aspirin and Apixaban treated patients. And of course, bleeding events are very important. And you can see that numerically, there was no difference between major bleeds. In particular, there were no cases of intracranial hemorrhages in both arms. So that's very positive. And also the rate of major and clinical relevant non-major bleeds, which was the primary safety endpoint of the study, was not a difference. Although there was a significant increase of all bleedings, including minor bleedings in the Apixaban arm compared to the aspirin arm.
Coming to the subgroup analysis of the ATTICUS trial regarding the primary endpoint, we could again not show any significant difference between the two study arms, similar to what has been observed in the RE-SPECT study. And there was at least a trend with a P of 6% regarding prevention of new ischemic lesions in patients above 75 years. This is for sure a population with a higher prevalence of atrial fibrillation, but also other cardiac risk factors. And what is most important, there was no such observation or difference between the two study arms with regard to the two baseline characteristics that had been differently distributed between Apixaban and aspirin. So there was no advantage of either medication patients with PFO nor in patients with a history of cancer.
So there are certainly some limitations of ATTICUS, the small sample size and the preliminary termination of the study due to futility. There were new ischemic lesions detected by MRI as a primary endpoint. Of course, we cannot say for sure how clinical relevant these endpoints are, but there are indications that there are strong associations with recurrent ischemic stroke. And of course, the frequency of recurrent stroke, so clinically manifest recurrent stroke, was similar to that in both larger randomized trials. Of course, also when looking at divergation of the Kaplan-Meier curves, in particular in the RE-SPECT ESUS study after 12 months, a limitation of the ATTICUS trial is that we stopped the follow-up at 12 months, but of course we are aiming to prolong the follow-up of these patients to see whether there will be differences in effects.
Okay, to summarize the results of the ATTICUS trial, we were the first studying the concept of DOAC versus aspirin in an enriched ESUS population, meaning that patients enrolled had additional risk factors for cardiac thromboembolism, mainly AF predictive factors that we had already evaluated in a previous small study. So CHA2DS2-VASc score equal or over 4 as a clinical predictive factor. Then echocardiographic predictive factors such as LA, left atrial dilation, slow or low flow velocity in the left atrial appendage or spontaneous echo contrast, and finally atrial high rate episode in the 24-hour Holter ECG. Then we could not show that Apixaban was superior in this setting. However, we have to say that aspirin arm was somewhat optimized due to the mandatory cardiac monitoring, leading to an immediate switch or a soon after AF detection switch from aspirin to direct oral anticoagulation with Apixaban in the 12 months of follow-up. And then we had to highlight, due to this mandatory cardiac monitoring, we are able to detect AF in a very high number of patients, 26 overall, and even 28 in the aspirin arm, leading to the just mentioned switch of medication in a third of patients. And finally, we were able to show that the early start of direct oral anticoagulation with Apixaban after index stroke seems to be safe, at least in this trial, leading to no increased risk of major or clinically relevant bleeds, especially no case of intracranial hemorrhage. It's
of course a challenge to discuss the implications of ATTICUS. So first of all, I think we could show that atrial fibrillation has a high prevalence here in this population. So that's an important message. And of course, this implies the antithrombotic treatment in this population. I think we could show, and this is a proof of concept actually, that early anticoagulation is not associated with adverse signals, in particular no bleeding. So either early anticoagulation using Apixaban or individualized treatment leading to switching of aspirin guided by intensive monitoring, ECG monitoring, was associated with actually low is a low prevalence of ischemic endpoints in this trial. Just remember, we did our sample size calculation anticipating that the rate of the ischemic endpoint would be much higher based on previous observational studies. So actually, we would have expected incidence of the ischemic endpoints of about the size of 2 times after 12 months. So actually, we achieved something with this kind of treatment. And thus, we believe that this concept should be further followed in clinical trials and is a safe and effective treatment.
Further analyses on AF occurrence, AF burden, duration, start, etc., and also the macroangiopathic changes that have been related to ESUS will be analyzed and will provide more detailed information which subgroup of our patients may especially profit from an early start of Apixaban compared to aspirin. But as Tobias said, the main message at this point of time is that we can use both approaches in the same way. So Apixaban right way, or aspirin, however, together with mandatory cardiac monitoring in order to switch as soon as atrial fibrillation occurs. And there was no signal showing that aspirin would be more effective in the non-AF patients in our trial.